Welcome to the Straight Talk Physio podcast with your host, Dr. Andrew Junak and Dr. Craig Giambattista. On today's episode, we're going to talk about what a tendon is and what happens to the tendon itself when it gets aggravated, common places of the body that experience tendinitis, how we know we're actually dealing with tendinitis, and how we go about treating this type of tendon pain. Tendon pain is actually one of the most common things that we see in the clinic, so we decided to put together a little something here for you guys today. So Craig, do you want to kick this off and tell us a little bit about what a tendon is?
Yeah, let's go for it. So tendon stuff, definitely one of my favorite things to treat. And like you said, a super common thing. And this is going to be part one of two. So there's many different type of tendon injuries we can have. So this is just going to highlight the kind of tendinitis. And then we're going to kind of bump onto some other things, our tendinosis / tendinopathy. So stay tuned for the second one here. But just our basic review. What is a tendon? So not to get too sciencey, but it's a fibrous band of connective tissue that attaches our muscle to our bone. Basically, it's made up of collagen, which is something that is elastic, so it has a little bit of stretch to it, but it's also strong enough to where you can stretch it and it's not going to break. Along with something called a tenocyte, which are just basically specific cells that are found within the tendon. And their job is to respond to different mechanical loads. So if you listen to our talk about, some imaging stuff, we hit on this before, but the analogy we use with bone is called Wolff's Law. Basically, the amount of force we put on bone, it will make it react in a specific way. So if we are constantly weight bearing on our bones, it will add more bone and it will become stronger. If we're staying off our bones for a while and not using them, then they will break down a little bit. So tendons can kind of respond in the same way. So our body's in this constant state, building up, breaking down, building up, breaking down. It's happening at a level that we don't really feel it, like we'll never actually notice it. But depending on the forces that you predispose to a tendon can absolutely change what's going on at a cellular, chemical, and kind of like a structural level down there. So their main job, as you can imagine, is when the muscle produces some sort of force or some sort of pull, or when the muscle tightens up, it pulls the tendon, and then the tendon pulls on the bone that it attaches to, and it produces movement. So basically a tendon's job is to transmit force from our muscle to our bone. So with that being said, after our basic little anatomy review there, what is tendinitis, Drew? Can you talk about that and just kind of give us our basic definitions?
Yeah, so tendinitis is the inflammation of the tendon. So that portion that connects the muscle to the bone can actually just get overused or overloaded. And due to that overload or constant tension or pressure that's being placed on it, you can develop very, very small micro tears. Sometimes these can be seen in the case of a tendinitis, but many times these can actually be better visualized later on in the tendon process. So there are different phases to a tendon. So like I said, the tendinitis is the inflammatory phase. Other phases are a tendinosis, or what we call like a tendinopathy. And those are denoted based on the level of the micro tears and the time that the pain or the tendon has been irritated or aggravated. We can also visualize this a little bit better with ultrasound, or we can see some of these different changes to the tendon. And then through an MRI, if somebody has a tendinitis, for example, we'll actually see an increase in like the signal intensity. So it'll show up a little bit more white in the region where the tendinitis or the inflammation is located. From a tendinitis standpoint itself though, so as I mentioned, there's tendinitis, tendinosis, and tendinopathy. Tendinitis is kind of like the beginning stage. The tendinosis and tendinopathy are way further along, and we're going to touch on those a little bit more in our next podcast episode, part 2 of this. But the tendinitis in and of itself has no big structural changes yet. So when they look at that tendon under an ultrasound or even from an MRI standpoint, you won't see any different changes within the tendon. On the MRI, you'll just see that increase in signal intensity, basically saying, hey, something's going on here. There's inflammation within the area, and the same thing from an ultrasound standpoint. And there's a number of different places in the body that we can see tendinitis, or tendinitis typically happens. Craig, what are some common ones you see in the clinic?
I would say, me personally, the biggest ones I tend to see probably are around the ankle. So Achilles tendon, everybody knows that, especially if you're out there, doing your box jumps, or if you're a runner, if you're doing sprints in the knee. So our patellar tendon is huge. So that just, bottom of the kneecap pain. Again, a lot of people working out tend to experience that one. Hamstring is a super common one. You see that a lot with like your runners, specifically like sprinters, hurdlers, soccer players, punters, anything where we're doing that kind of quick kicking motion, definitely a common one. We'll see it a lot in the hip, actually, believe it or not. So a lot of time lateral or outside of the hip pain is commonly misdiagnosed as something else, when it could, very likely be a hip tendon problem we have going on. And even the adductors, who are groin muscles, see that a lot, again, in like athletes that are doing a lot of, multi-joint movement, maybe even some of our yoga people, definitely hockey players. That's an area that you see a lot, super common there. In the upper extremity, we're talking shoulder, so definitely see some rotator cuff tendon stuff. And I mean, anyone that uses their shoulder is predisposed to that. So we tend to see the shoulder stuff on a wide gamut, from your working person to all the way to your younger athletes. It just kind of spans the whole spectrum there. And if we're thinking rotator cuff, we do got to remember it is 4 muscles. So those are 4 different spots that we kind of run the risk of maybe something like this happening. And then also the elbow. So a lot of like racket or club or like bat sports. So we'll see it a lot with like tennis players or people that play golf. You'll tend to see that either inside or outside of the elbow pain. Sometimes even like a baseball pitcher, we'll kind of see that sort of stuff. I think one of the big take homes here, or one thing that we didn't mention, is the spine. So there are many muscles that attach to the spine. There are many little muscles that span 1 or 2 spinal segments. Maybe it's just not researched enough, or maybe it's not a lens that we tend to look through often. But I would say the common place that we're seeing a lot of this tendon stuff is in the extremities, likely because they have a big range of motion. They can be moved quick. And tendon-wise, we're just more predisposed to that kind of stuff. Not to say that it's impossible to happen at the spine. I'm sure in some way that it has, but definitely more of an extremity thing. So anything to add there, Drew? Anything you tend to see being in, more of the CrossFit realm?
I definitely see tons of tennis elbow and golfer's elbow, rotator cuff issues, gluteal tendon, tendinitis. Not so much adductor tendonitis with this population. In a small subset of the hockey players that I have seen quite a bit of adductor tendonitis. I see a lot of patellar, hamstring, quad tendinitis. And then in the summer and spring, when people are out running, because the way that most CrossFit gyms work is everybody's inside all winter rowing, biking, and then they really don't have access to running outside in the cold, or at least most CrossFit gyms in my area don't. So because of that, when the spring hits or the weather turns, everybody gets out and starts running, and then I see this huge uptick in Achilles tendonitis and plantar fascia, almost like a heel pain that starts to spur up over the course of time. But you mentioned that we don't see this a lot in the spine, and I think that's a really great point. I almost wonder, because the disc itself acts as more of a shock absorber and transmits some of that force, because of that, maybe the muscles and the tendons aren't having to absorb or, put out that much force to get your spine to move. I don't know, because I'd agree with you. I don't see it very often in the spine, or at least if I am seeing it, I'm not treating it as a tendon problem. Most of what I see spine related has more to do with the vertebrae and the disc itself, what's happening there in relation to the spinal nerves. With that being said, like, tendon injuries are so common. We see this daily in all these different areas. How do you think it happens? Like, where do these things come from?
Right. Great question. I think in the tendinitis, realm, true tendinitis, we're looking at overuse or overload or too much volume or going too heavy or too sudden of a movement. So basically we're doing something that the tendon is not used to, and it's responding, appropriately. It's kind of like, hey buddy, we got to back this up. This was way too much too quick, or this is way too much volume, or, we're not used to this. And that's when we start to get that inflammatory response. It's kind of like your body reacting to that abnormal situation. It's like you've flipped the switch for the alarm real quick. So a lot of times people will notice, they'll come in and say, you know what, I did this and now it starts to hurt. It wasn't like it hurt a little bit and then a couple of days went past, now it's a little worse. And then, a couple of days went past and now, it's a little worse. I mean, can that happen? Yes. Can you injure tendons just by, putting pressure by sitting on them? Of course you can. But I would say more often than not, we're tending to see something kind of specific. And it doesn't have to be like an athletic movement. It could be as simple as I bought some groceries and I lifted the milk jug up with my arm and now all of a sudden, bam, it hurts really bad. Another, sometimes overlooked thing, and I would, classify this a little bit more on the rare end, is there are some medications that can cause or predispose you, I guess would be a better term, to some tendon injuries. And I am for sure going to butcher how to say this, but the category of medication is a fluoroquinolone.
That was pretty good.
So I'm sure there'll be like some pharmacist or some MD out there listening to be like, wow, that's not right. So anyways, it's an antibiotic for a lot of things like UTIs and respiratory infections and all that kind of good stuff. If you do take those medications, not saying don't ever stop taking them, consult your medical provider before we'll do our quick legal, our legal overlay there. Do not stop taking your medications. I can't be more clear than that if they're prescribed to you. But it could just be interested to see if this is something you're taking. Like I said, if you are taking an antibiotic, look up the generic name and it might be, something under this umbrella there. So anything to add there, Drew, as far as how does it happen? And then if you could speak about so if it does happen, what might be something that the patient would experience, or what do you hear them say when they come in?
Well, you know what, real quick, going back to the medication standpoint, I think a lot of times patients come in and they say, why do we need to talk about medication? Because a lot of times I'll ask medical history, what medications are you taking prescription wise? And patients kind of wonder, they give me this funny look why do you need to know? Well, there's situations like this that come up where if you are taking one of those, the fluoroquinolones, I took a shot at it too.
Nice.
If you are taking something like that, it is important for us to know, because then that leads to building a case for a specific type of diagnosis. So when we are going through and we're trying to figure out what's going on with a patient, there isn't one specific test that we do that gives us all the information. It's a cluster of things. It's what you tell us as the patient. It's what our exam shows us. It's what's in your medical history. It's the big picture. And that's what we're trying to break down and look at. And then from there, we take all this information, then we come to a conclusion, and that's how we proceed with treatment. So I think that was a really good thing to mention, Craig. And then as far as what patients experience, so when somebody has a tendonitis, usually they're pretty uncomfortable. If it's very acute or just happened, the pain can be constant. After this very acute phase, the pain usually will ease and it will become more intermittent, more so to where you'll either have pain during the use of that muscle. So if it's in, let's say, your elbow, and it's more of like a tennis elbow, anytime you're using your wrist to turn a doorknob or rotate a steering wheel, those sorts of movements, it will start to aggravate it. Or let's say you're doing a workout, you might actually have no pain during the workout, but when the workout's over, you'll have this big flare up maybe an hour later or 24 hours later. And that flare up will actually be correlated to an overload. Usually the pain in and of itself is very local. This is a key component to this. Tendon pain typically does not travel to other regions. We see some spots where trigger points or little knots in muscle, you can press on one spot and feel it in other areas of the body. However, with tendon pain, we like to see majority of the pain be pretty local and not travel elsewhere. Because some of the things that we're always trying to differentiate is, are we dealing with muscle, tendon, ligament, bone, or nerve? And when we're trying to sort this out, nerves can radiate pain to other areas of the body. Certain joints can present in different patterns. So when we're going through our exam, looking for the locality of it and knowing that there's a specific point at which most of this pain is originating from at all times, that's important for us. Also, it's accompanied by a burning and aching. Once in a while, if you're using it, it can actually be very sharp. So it really, it can be difficult to pinpoint whether or not you're dealing with a tendon problem, because things can be, somewhat painless to where you don't feel it unless you use it, or it can be so flared up that I've seen some tennis elbow pain that has just been super constant, super sensitive, to where you can barely like put your hand over the side of the forearm without somebody like pulling away. And then I've seen others where I can really kind of dig into the area and patients tolerate it very well. So there's definitely a spectrum when it comes to tendon pain. It's not a one size fits all. Is that similar to your experience?
Yeah, no, that's exactly the same way I tend to go about that, and I agree with you on all those points there, which kind of brings us to our next topic. And one thing you hit on is location being pretty key for it to kind of making sense of this whole picture. So I guess we'll move on to talk about is how do we know if it is tendonitis. So a lot of times we talk about doing our exam and doing our differential here. And I think that's a nice segue. But before we get into that, is like, why is it important even in the first place that we're recognizing what's going on? And in the tendon world, believe it or not, like you said, all tendon injuries are not created equal. And when we're talking about our tendinitis versus our tendinosis or tendinopathy, the treatment goals and the timelines are entirely different.
Yeah.
So with our tendinitis, as we said before, no big structural change to the tendon. Yes, there is some inflammation. So the prominent treatment goal for that is to reduce that inflammation and mitigate load. And it's likely, a shorter recovery, which is nice, which is we like to see that. So how do we know for sure it's tendinitis? And the big things is there should be some sort of mechanism that makes sense. Normally, we should be able to pick out in some way why it happened. That's not the case every time, but by and large, we should be able to at least, choose some event that is a major contributor, if not the number one cause. And then, like you said, the location is super important. So it should make sense. If we're thinking it's a tendon injury of our hamstring tendon, for example, we know the anatomy of the hamstring. We should be able to, when you point and show us where it hurts, it should be, pretty darn near close to that hamstring tendon. So from our end on the PT end, like what are some things that we do with patients to tease this out is if we go back and we look at the tendon's anatomy and what it does and its job is to, transmit load from muscle to bone, we're going to do things like stretch that tendon, stress that tendon, ask it to work. And then, in theory, it should bother you. And, we're not about putting people in pain, but to help us differentiate, we can bias certain tendons out or, bias certain movements that cause a specific tendon to work. And you say, you know what, that's what brings me in. That's definitely my pain. Those are some of the big ones that we use for, diagnosing this stuff. So is there any other tricks that you typically use, Drew, when you're looking at this stuff or any things tests wise, you're like, yep, that's making me think tendonitis or tendon injury for sure?
Yeah, I think the biggest ones are stretching, loading, and palpating or poking around on the tendon to see if we can recreate the cause of the pain or what the pain feels like for the patient. I think those are the big ones. And then also ruling out the other stuff, making sure there's no nerve contributors, making sure there's no contributors in any of those other areas that I spoke about earlier. But then on top of that, I think one of the biggest ones, and you touched on it, was some mechanism of injury that makes sense. And what we mean by that is, let's say you picked up a new activity that you don't typically do. So right now, I would say with the seasons changing and we're kind of going through this weird pandemic, a lot of people are staying home and a lot of people are exercising from the comfort of their homes. And because of that, running is becoming a more popular thing. Well, for a lot of people who CrossFit, and running was never really a big part. They probably wouldn't run more than 1 to 2 miles at a time. And now they've all of a sudden started to ramp up their running, and they're running 3 miles, 4 miles, maybe even 5 miles on any specific or given day. That makes things a little bit more challenging on these tendons, and the tendons themselves can get aggravated or inflamed. So by mechanism of injury, we don't necessarily mean like, oh, you fell and you landed on your hand, or you fell and you landed on your shoulder. That's not necessarily what we're looking for. We're looking for more of a change in your daily activities or an occupation or a job that essentially contributes to this. I've treated a lot of dentists who have a lot of tennis elbow. Well, that makes sense. They do a lot of fine movements with their wrists and hands and fingers, and they do this every single day for hours upon hours upon hours. So it makes sense for them to have some tennis elbow or lateral elbow pain. With that being said, there is some time frames to this stuff. So from a tendonitis standpoint, Craig, how long do you typically see this last? And then at what point would you say something is more tendonitis versus a tendinosis?
Right, and that's a great question, and I think there's a little gray area to that, and we'll hit on that here. But more often than not, when we're talking about like time for like a true tendonitis to resolve, we're talking like days to weeks normally. The research will say on the higher end 4 to 6 weeks, and that's where it gets a little gray, because I would say after like a month, and someone's been dealing with what they would consider tendon pain, or what we would think tendon pain to be, for more than like that 4, 6, 8 weeks, then my mind is going towards tendinopathy kind of deal. So at least when I see patients and I educate them on stuff, and they say, well, I think I have tendinitis, and I'm like, well, healing time for tendinitis, I'm thinking days to weeks, and then it should typically resolve on its own. Like, your body has a really good capacity for mitigating this kind of stuff, but once it lasts longer than that, and we're thinking maybe this is like a chronic tendon problem, this might be a tendinosis, then if you recognize it at an early stage, so which makes it super important to contact your medical provider, specifically physical therapist, you can knock that kind of stuff out. I typically tell people to expect 6 to 8 weeks, but if this is like a lingering tendinosis problem, the more serious tendon problem, then I tell people that it could take 6 to 8 months, or 3 to 6 months, excuse me. And in like really recalcitrant problems, like there have been cases where it's taken sort of 9 months. So as you can see, when we're talking tendinitis versus tendinosis, tendinitis typically way less serious, way less time, and that's why it's so important to differentiate between the two. So I don't know, Drew, do you have anything else to say on the time frame thing, or what are you doing to treat this kind of stuff, or how do you typically go about it?
As far as treatment for a tendinitis, I'm definitely more on the conservative side, because as we already know, tendinitis is caused by an overload or overuse or a sudden movement that your body wasn't ready to do. I have one patient in mind in particular that I can think of. She had a hamstring tendinitis. She saw me very acutely, like within the first 2 to 3 days. We start out with rest and ice. We went to a very light isometric. So what that is where you're creating tension within a muscle without the muscle actually moving through a range of motion. So think about it as like a prolonged hold. And instead of, moving through a full range of motion, you're just holding in that position, creating tension. Usually we'll do this for about 10 to 15 seconds for maybe 5 or 6 sets, trying to do something like that daily. We tried to do some activity modification where we actually deloaded the tendon or the different movements that the person would be doing in their workout plan, whether it be running, CrossFit, weightlifting, squats, whatever it is that they're doing. We have to deload and protect that tendon for a short period of time, because we don't want it to progress to a tendinosis. Usually the rate of recovery with conservative treatment is extremely high. We're looking at greater than 90%. So very few people actually go on to get surgery for this sort of thing. And then the role of surgery with a true tendonitis is really unknown, because it typically doesn't happen. So we don't need to go there. However, as a tendon becomes more degenerative over time, so say this tendinitis progressed to a tendinosis, or what we call a tendinopathy, there are surgical measures that may eventually need to take place if a tendon does completely tear, or there's a partial tear that just isn't completely healing from physical therapy, which is rare, but once in a while something like this does happen. So understanding the different ways that we manage and treat a tendinitis, tendinosis, or tendinopathy is extremely crucial to recovery. If you start to load a tendinitis too soon, you just continue to flare it up and the pain gets worse. So we're always using pain and the patient's feedback to help guide, our treatment and our plans. You have anything you do differently than that, Craig?
I would say I do the exact same thing. with kind of education being my big thing, because the
Okay.
main goal is we gotta deload the tendon, or we gotta change the amount of load that's placed on it, and then we gotta gradually get back to what we were doing. So, and a lot of times, which kind of brings me, I think we can finish up here with some of our key points or our key takeaways. It's a nice segue because it brings me into the biggest one that I talk with people a lot, and that's if you have tendon pain for a long time, then it's not tendonitis. So
Yep.
in the medical world, or at least on the physician end, or the referrals that I see, is like the term tendonitis is so commonly used in the medical community that, like, if a lot of people that have just tendon pain of any origin, someone just puts down there, yep, you got patellar tendonitis, and patients come in and say, well, I have this tendonitis, when in fact the terminology being used is likely wrong. So the typical tendonitis thing, we actually medically don't see these people very often. Now, Drew, you might do, because you are in tight with your community, and you might see people immediately when they get injured. But if we look back at our time of resolution for a true tendonitis, if it's days to maybe a week or two, a lot of times people will get injured and they'll say, you know what, I really hurt my shoulder after lifting this thing. I'm going to wait it out a couple days. And then, you know what, if it's still bugging me, I might call my doctor. And then by the time that they're seen, or they're, they end up getting a PT, it's like 2-3 weeks later. And by that time, their shoulder pain might be completely gone, and, they don't even need to come in, kind of deal. So that's what I more see on the tendonitis end, and like that, the outpatient clinical setting, or the stuff that I'm most familiar with. So if you do see me, if you make it that far, it's likely a tendinosis or a tendinopathy problem, and it was just inappropriately named. And that's no one's fault. It's just kind of a medical habit that that needs to be that kind of needs to be broken. So that's my little soapbox there. But I would say more often with this true tendonitis stuff, there's many times where you don't need to even see a medical provider. Things,
Yeah.
Tend to resolve on their own. Now, the problem arises if this is something that becomes frequent, or something that doesn't go away, then catching it early is crucial. And I would even say that if you have direct access opportunities with the PT, if you do feel like you have this tendon problem, that initial, at the very minimum, education is going to help you get better faster. And then, might even be able to pick out why this happened in the first place and how to stop it from happening in the future. So any other big key points you have there, Drew?
Yeah, I think, tendon pain gets in the way of a lot of different things, from simple tasks to job duties, workouts. I mean, tendon pain really does stink in and of itself. One of the tougher parts about treating tendon pain is you don't want to do too much too soon, but you also don't want to wait too long. So there's this happy medium of, if you have tendonitis and you go see a medical professional who isn't skilled at identifying a tendonitis, or isn't able to make that diagnosis, or isn't comfortable with that, then they might start to load you too soon, and then you might end up this becoming more of a lingering problem and drawing it out further. Conversely, if you wait too long and you don't do anything about it, then tendons do end up in a place where sometimes bringing them back doesn't always happen, and it leaves you more prone to tendon tears and different things like that can eventually be surgical in nature. So there is a sweet spot with this. I would say if you do start to have tendon pain, it's a good idea for you to take some time and go see a medical provider, get it evaluated, and then kind of go from there.
And then one more thing, if I could add it before we hit our wrap up here, as long as you don't have anything else. So my one little soapbox coming at you here, my one little gripe with this kind of stuff is if we circle back to saying the importance of catching this stuff early and understanding the difference between a tendinitis and a tendinosis. Tendinitis, like we talked about earlier, is inflammation to the tendon. So naturally, our first course of action would be like, what things can we do to reduce inflammation? And we, on the PT end, we hit a bunch of R things that are very effective. But on the medical end, sometimes you'll see people getting prescribed very high dose non-steroid anti-inflammatory medications, or your NSAIDs, even steroids in some cases, or cortisone injections. And if we if we think about this tendon stuff and in the tendonitis world, how quickly it should resolve, then likely if patients have gotten all the way to that point, and they're getting these, high dose anti-inflammatories or these, this steroid medication, they're likely in the tendinosis or tendinopathy stage. And at that point, it's not an inflammatory problem. Those kind of treatments are not advocated for that kind of problem. And in some cases, steroids and high dose non-steroid anti-inflammatories, I mean, the research is back and forth on this one, but there's a potential for it to actually be damaging a tendon. So anyone listening to this, I would caution using those, like what I would consider on the more extreme level, when, we got to be diligent about knowing what we're dealing with first.
Yeah, I would almost say as well, I've had a few patients in the past where the first sign of any tendon pain, the first thing they do is they go get an injection.
Yeah.
And we know that there's also, depending on who you talk to, there's lifetime limits on how many injections you should have in a lifetime. Some will limit how many you can have within a year or within a certain number of months. And we also know these injections of cortisone and some of these other different things can actually have some degenerative capabilities that could negatively impact that tendon in the long term. So we definitely have to watch out for some of this stuff, and especially if you're not in an inflammatory phase to begin with. So just like you said, if the tendon is actually in a state of tendinosis, then it doesn't do us much good at all to hit it with all this anti-inflammatory stuff. If the inflammation isn't the problem, if the structural changes within the tendon are more of what we're treating and taking care of. All right, guys. Well, with that being said, thank you so much for tuning into the Straight Talk Physio podcast. If you like what you're hearing, it would mean the world to us if you subscribe to this podcast and the Peak Physiotherapy and Performance YouTube channel. For more information about us, please check us out on Facebook at Peak Physiotherapy Performance, on Instagram at P3 Physiotherapy. For more information about Craig, you can follow him at Dr. Craig G_PT on Twitter and Instagram. If you have any topic suggestions, comments, or questions, then feel free to email them to us at thestraighttalkphysiopodcast@gmail.com. Thanks again for watching, and we hope you guys have an awesome day.